Let's focus on 4 functions of the liver. So your liver does drug metabolism, correct? Your liver also produces bile and it's stored in the gallbladder. Third, your liver synthesizes protein, albumin. Fourth, it is responsible for clotting factors. Okay, so if the liver fails, what happens to these 4 functions? They're gone. Okay, so those are the focus of your problems. So the cause of death for these patients will be related to the loss of those 4 functions. We'll take a look at and a slew of complications will result. Okay, because of the location and function of the liver. First of all, anatomically wise, where is it located? Okay, under the right lung. The last blood vessel before it becomes the inferior vena cava is the portal vein. So if the liver is diseased, what happens to that portal vein? It's also going to constrict. It's going to be occluded. So what happens to venous return from all the GI tract and the lower parts of the body? What happens to venous return? What happens to cardiac output? Okay, so that's just one of the problems. Because the venous return is decreased, so the blood vessels, the blood coming from the esophagus, actually from your throat, to your rectum, your feet, all drain into the portal vein. If they can't do that, what will be the result? Let's start with the esophagus. What will happen? What will happen to the veins that in the esophagus? What will they develop? What do you call those dilated blood vessels? Dilated veins. Varicose. So the patient will develop esophageal varices. So every patient has a diagnosis of cirrhosis, which is end-stage liver disease. What should you always watch them for? Bleeding. Okay, esophageal varices bleeding. They can bleed to death. Are we clear? The problem with this is, where is the vein? So let's say this is my esophagus. Okay, this is my esophagus, and then the food goes in there. The vein is not only outside the esophagus, it's inside. So if the patient swallows anything hard, chicharron, or anything else sharp, chips, can it cause bleeding? They can nick those varicose veins in the esophagus, causing massive bleeding. Okay. Anyway, that's just one. So let's start here. So the largest organ of the body, liver, and I emphasize those 4 key functions. So here is the structure of your liver. Yes.
So when they have liver issues, the main means is bleeding.
Say it again.
When they have a varicose vein,
Yeah.
the main is bleeding.
Bleeding, yeah. They can literally bleed to death.
Yeah.
Because these things are so big. These esophageal varices are so huge. Okay? They can be this thick, this big. This pops, what will happen? Yep, non-stop. So here are your hepatocytes. The good thing, which is kind of a bad thing also, is the good thing is the liver tissue, the liver cells are very, very resilient. Meaning this organ here, this is the size of the organ, right? Even if you only have a small percentage, let's say 5% left, they will function. Okay, they will function right till the end, which means if the patient already has symptoms, is it early or is it too late? Kind of too late already. So once the patient has one episode, they already turned yellow at that point. Usually they're in the middle or late stage already. I mean, I'm not saying they're going to die today, but it's going to be a long, painful death. All right. Yes. Typically, yes. Only to a certain point because you have to anastomose it to something. Okay, you have to connect it to something. So here are the other functions of the liver, which will also affect which will make sense why your symptoms will be such and such. So it's responsible for glucose metabolism. Remember, it stores glycogen. Okay, and we have ammonia. It will get rid of ammonia. So therefore, no liver function. What happens to ammonia levels? So one of the complications is encephalopathy because of you're poisoning your body. Okay, the ammonia will make your brain crazy. Protein metabolism. So at a certain point in the disease, we have to control the amount of protein because where did ammonia come from? These are amino acid metabolism. So the more protein you give, then the more ammonia you make. So no liver, you can't get rid of the ammonia. So we'll have to control it at some point, which is a catch-22 because the patient has a diseased liver. It needs protein to heal, correct?
Yeah.
So you're damned if you give too much. You're also damned if you don't give enough, right? So it's very hard. So that's why it has a high mortality. And then there's fat metabolism. So now you can't, it produces bile, right? So you can metabolize fat. So no bile because so what will happen to fat soluble vitamins? Okay, so you'll be malnourished. So cirrhotic patients are malnourished patients. And here's the others. Again, bile, and then you need that for fat metabolism. Vitamin D, vitamins, fat soluble are A, D, E, and K, correct? Okay. Also vitamin B. And then because drug metabolism occurs in the liver, so are we still free to give whatever drugs to treat this patient? Now we're limited again. So this another problem. Yep, nothing good comes out of this. Okay. We'll talk about hepatitis separately, which is short. So now let's begin with the assessment. So we look at the history. Number one cause of liver disease is alcohol. Okay, so that's just one though. We also have viral causes.
Yeah.
But most common is alcohol. We call that
Alcohol base.
forgot the term. Lennox cirrhosis. Okay, Lennox, Laenec. Lennox cirrhosis is alcohol. So here are the assessments. So blood work, we will look at the patient's profile. What are the two liver enzymes? ALT, AST. Very good, children. And then again, we'll look at so what's responsible for the pale colored stools? Why does the stool look white? Okay, no bile. Okay, so no bile. And of course, the stool will be really, smelly because there's fat in there. It can't absorb fat. Okay, so there's fat in the stool. Okay, they're very pasty, really nasty smelling. Plus, in the later stages, they'll also have fetor, hepatic fetor, meaning their breath smells like poop. Okay, and then that's I forgot the term. Anyway, it should be written here somewhere. Okay, so once you have low albumin, so it will now mean that your plasma, does it have enough osmotic pull?
No.
So you'll start having edema because now your plasma can't hold water because you have low albumin. So now water leaks, so you'll have edema in your extremities and in your abdomen. Plus, not to mention the pressure in the congestion, again, traffic in the portal circulation will cause hydrostatic pressure to increase, pushing water even more. So two causes of the edema in the peritoneum. So the ascites is caused by, again, the hydrostatic pressure because of congestion, meaning portal hypertension, plus the low albumin in your body. So two causes of edema. So the patient really looks like they're in fluid overload, but really, are they in fluid overload?
No.
They're actually in deficit because the water is third spacing. Okay, it's not in the bloodstream. Okay, your blood can't hold the water, so blood pressure is low. But then patient looks like they're very swollen. So it's hard to give diuretics because it will drop the blood pressure even more. So the liver is normally not palpable. Okay, so if it's palpable, that means it's enlarged. That's a sign that you have beginning liver disease. Of course, there's acute and chronic forms. Obviously, cirrhosis is chronic. You can have acute liver disease, let's say from hepatitis, for instance, could be drug-induced or virus-induced. Please take note of the numbers because I'll just go with numbers. However, to be fair, this is NGN, so there will be normal values as well.
For the ALT.
Yeah, so you'll have 3 columns. Okay, so you have the normal range and the
Oh, there's some other
result. So yeah, so it'll be like this. So you'll be given the reference range. Okay, all you need to do is interpret.
Everything, whatever. you say.
Yep. But again, I'll give you the
Yeah.
numbers. Okay. So here's the protein. Again, I'll give you the reference range and the patient's results. Well, not all, because there'll be a long on the question, so you'll be scrolling a lot. So I'll just pick out the AST, ALT, albumin protein.
Okay.
Yeah. And cholesterol and ammonia. There'll be a combination also because what will happen to the bleeding times here?
It's gonna increase.
It's going to increase. Okay, so your PT, PTT will be higher. All right, INR will be high.
Oh, okay.
Okay. Will this affect platelets?
Yes. No.
No.
It's the bleeding clotting.
Yeah, only the clotting factors.
Yeah.
Platelets is from the bone marrow. Okay, the liver has no role in platelets. Are we clear? So only your bleeding times will be affected. Okay, let's get to the problems. So jaundice is never a good thing. Jaundice indicates that you have increased bilirubin and your body is not able to get rid of it. So it leaks into the skin and also in the sclera of the eyes. Okay. And what happens to the color of the urine? Dark. Okay. Yes.
For a patient that is really dark skin, how would you?
They will still turn yellow. Yeah. Yeah, the skin will have a yellow tone, yellow tint to it. And of course the eye. Because no matter skin color, our eyes look the same. Our sclera will always be white. And you can also see it in the palm and also on the sole of the feet. Okay.
The pollen's gonna be yellow.
Yeah. Okay, portal hypertension. Again, this is caused by congestion. Okay, because the liver, you've seen liver tissue, right? In the grocery. It's soft, right? It's red, soft, indicating, is it vascular?
Yes.
Very vascular. Imagine putting it on the grill for just 2 minutes. Okay, so your grill is already 300 degrees, and then you put the liver on there. Just 2 minutes on each side. What will happen to that liver? That's what it looks like when it's in cirrhosis. Okay, that's what the liver looks like. Okay, it's like the liver was on the grill for even just 2 minutes on each side. Okay, when we say cirrhosis, that's what the alcohol did. All right.
Yeah.
So what happened to the blood vessels now? All constricted, if not blocked. Okay. So that's what causes the portal hypertension. And once this occurs, there will be a snowball effect now. So what will cause the esophageal varices? It's this one. What will cause the ascites? This one. Okay. So this is now the root cause. Okay, once portal hypertension develops, and of course, no matter how much beta blockers you can give, it will help. You know, you can give propranolol, but I mean, only to a certain extent, right? So here's the ascites. Now the ascites here, we can have peritonitis as well, because the longer this fluid stays there, even though the peritoneum is sterile, supposed to be, because this fluid is leaking, so there'll be some normal flora that will be mixed there. So therefore, it can cause peritonitis because that bacteria is not supposed to be inside there, right? So this can also impair breathing because now the belly is this big, bigger than 9 months. Okay, so now it will press against the diaphragm. Patient can't breathe. They go to the ER. We drain it, and then a few weeks later they come back. The same thing. All right. So the albumin is low, again contributing not just the portal hypertension, but the hypoalbuminemia will contribute to the ascites. Mhm. Therapy, of course, will it help that we limit the sodium? Yes. Okay. So here, sodium will be limited. Check about potassium again, okay, because these patients, remember, will have some heart disease, right? Okay, so they will have some effect on the heart, not to mention the kidneys also. There will also be hepatorenal syndrome. We just watch it. Okay, so not necessarily restrict, because there's very few instances that we restrict potassium simply because plus as long as the kidneys are okay. Yeah, but again, there's hepatorenal syndrome here, so this can lead to CKD. Yeah, so once there's evidence of CKD, then you have to limit the potassium as well.
But most salt product has
Yeah, potassium, I mean, salt definitely we limit. But again, for commercial salt substitutes, what are they made of? They're made of potassium. So instead of sodium, they use potassium in. I thought we discussed this in heart failure last month.
I don't remember.
You need to be examined for dementia or. All right, so management for ascites will be paracentesis. Now take note the structures around. So in my belly, okay, so what's in here? Is it only the liver?
No.
Okay, so we have the stomach here, right? And then the small intestines in front, and then all in the perimeter will be my large intestines, correct? Okay, so the fluid here, when it accumulates, is it in one spot?
No.
They're in between loops of bowel, in between the pancreas and everything. So when we tap it, so it's now this big. Where will liquid accumulate? So is it wise to tap it here or here? At the bottom, because it will drain like a faucet, correct? Now what's here?
Bladder.
My bladder. So therefore, what should you do before the patient goes to the procedure? Have them pee. If they can't pee, then scan the bladder, and then if needed, straight cath. All right. Do we weigh the patient before the procedure?
Yeah.
Okay. Do we record vital signs? Do we hold anticoagulants?
Yes.
Yes, if we can. Okay, if it's safe to hold it, but not all people can do that, because some people do have heart conditions, for instance. Okay, because when you're alcoholic, is this your only problem? If you're alcoholic,
No.
you have other problems. Okay? Yes. Yeah.
How long is the procedure?
Just a few minutes.
5 minutes.
Yeah. So the nowadays we're in a advanced country, so we do paracentesis using ultrasound guidance here, meaning the ultrasound tech will be summoned and asked to map out they'll literally draw on the patient's abdomen. So they'll draw circles telling the doctor where are the largest pockets of fluid. Okay, because does it make sense draining small pockets or the biggest one? The biggest pocket. Okay, then the patient will be, of course, asked to move around, okay, to move the fluid. So yeah. Okay.
How many will it be?
Here,
Oh.
as much as the patient can tolerate. So you can remove up to 5 to 6 liters. That's a lot, right? So a lot of bottles. These are all fluid. So what's gonna be obvious complication after the procedure, hypotension. And bleeding is not really a concern because the needle is so small. We just put a Band-Aid over it. But just watch the site. But typically we don't have, even if the INR is so high, because the needle is so small. But very important is the voiding, okay, voiding and then weigh the patient. Yes.
Any electrolytes come out with that paracentesis?
Yes, of course, you lose sodium, potassium, electrolytes. Yeah, because that came, where did that fluid come from? The blood vessels, they leaked out. Okay, so along with it will be trace electrolytes. Tips. We don't routinely do tips. So look at the indication here. Who gets tips? These are patients who have, here, look at this. Transjugular intrahepatic portosystemic shunt. Okay. So what is it? It is a shunt. I'll show you shortly. So let's look at the indication. Who gets it? So the purpose is to reduce portal hypertension. Another is the patient already has repeated paracentesis, meaning they're coming in ridiculously frequent. I mean, twice a week, 3 days a week. It's not safe. Okay, we can't keep doing this. So we'll just basically, is it done early or late? This is a late procedure. Okay, call it a last resort. All right, I'll explain why. The tips is let me show you a picture. Here is where the shunt is placed. It's going to bypass the liver altogether, meaning blood, instead of passing through liver blood vessels, you know, the portal vein and everything, it will bypass the whole thing. It will go through the shunt straight into the inferior vena cava. While that's good for ascites, remember I said, what kind of organ and cells do the livers have? Resilient, right? Meaning even if there's very little liver function, whatever's left will function, okay? So even if, let's say, there's only a few thousand left, will they still continue to filter the blood, clean it? Will they still continue to metabolize drugs, including ammonia? Yes, but if you bypass the whole thing, are those functions still around, especially the ammonia metabolism?
No.
If you bypass it, is it still there? No. So that's why this is a last resort, because once you put this shunt, that means the blood is never going to go through those cells, meaning you will have zero ammonia metabolism, zero drug metabolism, nothing, because you're bypassing the whole liver. Yes, after the procedure, the ammonia levels actually increase because now you're bypassing the liver. Right. So that's why you understand why it's late, right? Meaning we don't go doing this as a first, intervention. So we do this only if there's nothing left to do. End stage, the patient's gonna die anyway. Let's do this. Okay. Yes. Yes, it will improve the ascites though. It will improve, blood pressure because now you're returning blood return. Blood return is improved, but the problem is ammonia. Okay. Say again? No, this is now end stage. Again, late stage now, just to manage, because is it nice to have a dying patient come to the ER 3 times a week for draining of the fluid? Is it nice to let them keep having shortness of breath because the fluids keep accumulating in the stomach? No, this is just for comfort measures. But again, the bad side effects is the ammonia will increase. Okay, but we have interventions for the ammonia. Okay, we'll get to that shortly. So you understand how this works? Okay, so again, is it early or last? Okay, late. Okay, last resort. So here, due to a higher risk of encephalopathy and higher cost of the procedure, so is this a first line? No, yeah, most likely last resort. Okay, when we have nothing else we can do for the patient. So I saw my uncle's cousins go through this. Okay, all my cousins on my mother's side. Well, my father's side didn't really have family in the Philippines. So yeah, all my maternal relatives were Escardas are alcoholics. Yeah, Escarda is my mother's last name. Long story why I'm taking.
No, are you not alcoholic as well?
No, I mean I would say alcohol. No. I mean I get to work, right? Yeah, I'm working. I even work in the hospital, so I don't have a problem.
I thought better.
So just like any patients with fluid problems, fluid balance problems, you obtain weight, you watch the urine output, okay, and watch heart function as well. The varices, okay, again, assume that every patient that has cirrhosis has this, okay, because they don't get to the late stage unless this is how they happen. All right, so you assume they have, and we don't know how bad it is, but watch for bleeding. Okay. Once they form, can only get worse from there. It does not get better. So bleeding here, it's fatal if they lose at least let's say 30% blood volume. So again, so here, what's the number one cause of mortality? The esophageal bleeding. Okay, so this is the cause of mortality in liver cirrhosis patients. So this is extremely serious. Look at that mortality, high as 40%. So here's one for ascites, kind of came late. The chart is below, but here it is. Again, for the procedure, it's also included here for the paracentesis. Okay, your responsibilities are here.
Okay. Management of the thyroid.
So people with varices, obviously, they will have alcohol because, again, Lennox cirrhosis is the number one. The other causes of cirrhosis are biliary obstruction. You have a gallstone, something like that. Or other causes could also be from post-herpetic syndrome, meaning after hepatitis, viral hepatitis B, C, that can also lead to cirrhosis or even liver cancer. Okay, but number one cause is what? Alcohol. Okay, Lennox cirrhosis. So signs and symptoms of this is really the bleeding, right? So and already tachycardia, shortness of breath, hypotension, right? Okay, and then pallor, diaphoresis, low urine output. So signs of blood loss or low cardiac output.
You're gonna go into the shower.
Diagnosis will only be done with an endoscopy. So patient will have an EGD. We have to visually see the varices. They can also do the treatment during the same procedure. No need to come back another day. So they see there's something we can control. They can do banding. So they can put a band. So these are dilated blood vessels, right? Like an aneurysm, but on a vein. So they can wrap it, with they can do as much as you can.
Because
but
I know my relative, he has to go. so
your
many
relative
times.
or
No, that's my cousin. He
Oh.
died.
okay, so you heard, of course. So whatever they can fix, or if they're small enough, they can do sclerosis. They can inject a sclerotic agent, destroying the vein. Yeah, condemning it. Yeah, condemning it, putting a sclerotic agent. So therefore, no more blood circulation in there. So no more bleeding. Okay. But again, they can only do so much for varices. So it's not a guarantee that the patient had the surgical intervention. Oh, I'm okay. Okay, it's no more. Okay, so they will be told, okay, you're lucky. Okay, but it's not gonna stop unless because what causes the varices? The portal hypertension. So unless you get a new liver, the portal hypertension will persist. Okay. So we fix the varices doesn't mean you won't form more. All right. The patient has to understand that. For the no, this can help. Again, diet modification will help. Okay, no more alcohol, nothing spicy. Okay, nothing like that. Because again, the varices are inside the esophageal walls. So when you eat, like really hot tamales, tacos, so that can cause discomfort, not to mention bleeding. Can this, okay, labs, yeah, you already know. So ALT, AST. Okay. Bleeding management won't be any different from any others. You know how to do blood transfusions, right? Okay, so that will be it. So which one do you give first, fluids or blood products? For what type of shock will this be? Hypovolemic shock. So which is your priority? Fluids or blood? Fluids first and then blood products. Okay. So nothing special. Drugs. For smaller bleeding, we can control it with sandostatin, octreotide. Okay, sandostatin is the brand name. The generic is octreotide. This will be infusion, IV infusion. This can also be given by subcutaneous injections. Okay, but most doctors have actually just received sub-Q maybe once. That's it. But all the other orders I received for these patients is always IV infusion. Okay, so this will control bleeding. Yes, sir. Philip? Oh. Yeah. So this is a vasopressor. Okay, so this will help control bleeding. Octreotide. So sandostatin is the brand name. Here's a hormone also, somatostatin. Okay, but it's not a statin drug. Okay, it is just, yeah, it's not related to that. So vasopressin can be used in lieu of, but this is for more high risk bleeding patients. But octreotide is the more commonly used one. For the portal hypertension, it will also help to relax the blood vessels. We give propranolol, okay, beta blocker therapy to also reduce bleeding. So the beta blocker use again is propranolol, right? We don't use metoprolol, it's propranolol. This is for acute bleeding. So if the patient is bleeding massively, I mean, like gushing out, vomiting, blah, really large amounts of blood, this is the option. This is only done in the ER. Okay, so patient comes in, bleeding profusely. He has, we do CAT scan. Oh, it's a bleeding varices. We insert the tube. Let me show you how big this is. You know what? It won't come out. It will be, the name of the tube is Sungstaken Blakemore. Look at the, look at the size of this tube. The diameter is about half of my arm. Okay, that big. So we're gonna put that through your nose. And it has two balloons through your nose. You're gonna put, or through your mouth. You can also put it through your mouth. There are two balloons here, one in the stomach and one in the esophagus. 2 balloons. So this will be inflated to press on the bleeding blood vessels. So this will be on for 24 hours. If it's in the mouth, what's your number one concern? You have a tube in your mouth. Aspiration. So is it a nice thing to have?
No.
No, dangerous for aspiration. So that's the danger of the tube. But it's nice, nice to see on the diagram. On a real patient, you don't want to be this patient. All right. So this is again this is a rescue procedure, okay, only done in the ER. And yes.
For 24 hours. Professor, those patients going to be intubated to feeding?
You can intubate, that's an option, but we don't have to. No, they're not eating. Yeah, you can't, yeah, but again, this is only for a short period of time. You won't die anyway. You're not fed for 2-3 days. We can keep you alive with IV fluids, but feeding is not a concern here. The bleeding is the priority. Okay, once we control the bleeding, then okay, we can feed you, right? So what's your number one concern when they have this therapy? Aspiration. Okay, so here. If needed, if the patient really needs this for a longer period of time, then we have to intubate, okay, to protect the airway and maintain them as comfortable as possible. Then just imagine let's say you become a nurse practitioner, right? And you're into critical care, you're the ones inserting these.
You're gonna be sleeping. They're gonna be
At this point, yeah, they will be sedated, given a sedative, because otherwise they'll be fighting. No, then they won't cooperate. And then other methods to control bleeding, you saw this in peptic ulcers, right? What was also given to control the bleeding? PPIs. Okay, so we will give PPIs or H2 receptor blockers. Okay, we already did tips, but let's look at what happens now after tips. What's the word I'm looking for? Okay, we won't test the surgical options, okay, including because you already tested on, tips is the shunt, meaning surgery here is meaning, removal of the liver. Okay, so that's, yeah. Plus with transplant, we did the transplant concept already. It'll be the same. This one will be, just happens to be a liver transplant. And we already know about rejection, okay, acute rejection. I think the next topic is encephalopathy. Yes, okay. So how do we manage this? So this is caused by what again? The ammonia. So a patient will go cuckoo because of the high ammonia levels here. They go crazy. The meninges are so irritated, the nerves. A patient will have severe changes in mental status. Okay, they become aggressive. Earlier on, there are different stages here, by the way. I'm not testing the stages, but in the moderate to advanced stage, the patient will have asterixis. So this is indicating that the brain cells, the nerves in your brain cells are already very irritable. This is the manifestation. You ask them to suspend their arms like this, and they will have flapping tremors. Okay, so we call that asterixis or hand flapping. Okay, so this is now indicating moderate to advanced disease. The problem here again is about injury because the patients are very violent. Okay, again, I saw all my cousins go through this. Yeah, I was a small kid, I said, and I always asked my friend, why does, Uncle Pedro have the same, he looked like cousin Tote. Hey, why do they look the same? And then again, my William, with in the case of William and Benjamin, I was already high school student, so I know what's going on. But I was a kid, when I saw my uncles, didn't matter. Uncle, aunt, they all had alcohol problems. Different stories, but ended up with alcohol abuse. Oh, here it is, Fetor hepaticus. So this is the crab smelling breath. Okay. It's nothing. The description here is sweet. Nah, it's nothing sweet. Okay. Yeah. Nothing sweet in this. Yeah. I don't know. Okay. Well, I don't know why they got that adjective. There's nothing sweet smelling about it at all. Okay. This is probably not testable on the NCLEX. I mean, this is constructional apraxia. They draw like this when the patient develops encephalopathy, and they write like that. Okay. Look at it, star, and this is their star now. Because again, indicating they cannot coordinate. Okay? Yeah, they can't coordinate the handwriting.
And when we say that.
Okay, medical pharmacologic management. Number one drug is lactulose. So the dose is however many to produce 2 to 3 soft bowel movements.
How many?
Yeah.
They're supposed to produce.
Yeah, so there's no set dose. Again, the basis is you give lactulose until they produce what? 2 to 3 soft bowel movements.
So once they do that, you stop.
Yeah, we can stop. Okay, and that's every day.
Okay.
Yeah, we want them to produce 2 to 3 soft bowel movements a day, because that's the only way. Because remember, the liver is gone.
Right.
So the only way we can get rid of ammonia is through the GI tract now.
Right.
Okay, so this is the only way. There's no other. There's no other way to do it. So here, 2 to 3 soft, okay, not diarrhea. Because remember, these patients have fluid volume problems, so we can't have them having diarrhea either. So just enough, okay. It's challenging. It's not this easy because remember, these patients have altered mental status. Will they take this by mouth? No. We'll have a problem. Yeah, that's another challenge. So it's very easy here. Oh, okay, give lactulose, but then the patient has changes in mental status. They're not always cooperative. So it's not very easy. No, there's no IV form. It's only oral.
Oral. How about
It doesn't work like Kayexalate. No,
Oh.
it has to be taken by mouth. Or you can do NG tube. It's an option. Okay, but just be careful because it's very thick. It may clog your tube. So make sure you dilute it. Okay, because it's very sticky liquid. Who's given lactulose? That really sticky orange solution. Yeah, that thing can clog a feeding tube, right? So you need to dilute that when you give it through a feeding tube. Yes.
You have. Keep giving the lactose. Even if they have
Yeah, that's every day. Every single day. Yep. This is forever. Forever. Yeah. Every day. Every day.
Okay, I get you now.
Yeah.
Oh, you stop daily, okay.
Yeah. Yeah, this is a daily thing. Okay, this is not one time, 2 to 3 bowel movements, and then that's it. No, this is forever. Every day. Correct. Yeah, because there's no way this patient can get rid of ammonia.
Oh, that makes sense.
So this is every day for the rest, however long the rest of that life is. Yep.
Wait, that's about the diarrhea.
Again, this is what you don't want to have. Remember, you don't want diarrhea either. So you just want soft, okay? Soft form stools, 2 to 3 of them. Yes.
So once they poop their first time, then stop giving them.
No, you need 2 BMs,
Two.
at least 2 or
Oh, I
3.
understand. Okay, I got it.
Yeah. So you give one, and then you have 2 hours later, they have a poop.
And then you
Okay.
stop giving it.
You give another one because we need 2. Yeah. You
And then
need.
once you get the second one, without the second, you stop.
Yeah. If there's no poop after 2, you give a third. We really want the poop.
You really want it.
Yeah. Okay, it's not a matter of BMs. Okay, but the lactulose will absorb the ammonia and then take it out through the stool.
That's the whole
Yeah.
thing.
So you can't use a laxative or a colis. No, it has to be lactulose. I mean, lactulose just happens to be a laxative.
Okay.
Okay, but it's the only one that works on ammonia. The others, the Dopolax, those things don't get rid of ammonia. Yes, ma'am?
I was just gonna ask you, like, what would be the lack?
Yes, also, yes, you can. Okay, for other interventions are non-soluble vitamins, meaning you give no, not vitamins, sorry. Antibiotics, okay? Non-absorbable antibiotics, meaning they just stay in your GI tract. This can also help. Okay. And remember I mentioned the dietary protein restriction?
Yeah.
Okay, only to this point, okay? Especially after TIPS. So after TIPS, we control protein. So the doctor typically draws ammonia levels. So the amount of protein we can give depends on how much ammonia is there. So if the ammonia is high, how much protein do we give? Less. If there's little ammonia or normal ammonia, we can improve we can increase the protein. Okay? So here, ammonia level is monitored daily. Right?
Who increases? We're gonna ask doctor or?
Yeah, doctor will prescribe. Because they order the lab, so they look at it and then they'll prescribe the protein for the day. Okay. Here's other. Yeah, but we don't do this routinely. Okay, so let's say the patient really has a severe episode, then we can give this. Mhm. Okay, so here's a summary of encephalopathy. This will contain the lactulose, the dietary protein restriction, the medications. All right. That should be it. Let's go to hepatitis now. And that will be it for the program. All right, so for hepatitis, you probably get about 5-6 questions on hepatitis. Yeah.
Hepatitis, okay.
Okay, so there are A, B, C, D, and E hepatitis. For cirrhosis, because this hasn't been tested yet, we'll probably get 12, 13.
Okay.
So for hepatitis, about 5 or 6. Now the questions will be restricted on 3 things. So because signs and symptoms are similar, so we will focus on, because these are contagious, right? Communicable. So we'll focus on what is the mode of transmission, meaning that will help you remember how to prevent it, correct? Other than immunization, because not all have a vaccine. Okay, so first is the mode of transmission. How does someone get it? So therefore, you know how to get it, then you know how to prevent it, because you avoid the ways that you get it. Second is the whether or not there's a vaccine. And then third is what your teachings will be for the patient. Okay, so again, how do you get it? The teaching will also include the other 2. All right. Okay. So A, B, C, D, and E only. Okay. A, B, C, D, and E. Now, please don't be restrictive. Okay. When you look at, especially on the teaching. So let's say A and E are oral fecal route, meaning you get it from contaminated food and water, right? Meaning oral fecal. So is it contaminated with what? Feces,
Yeah.
correct? Okay, so there's feces in the water, microscopic traces of feces in the water or in the food. That's how you get it, right?
Also,
But think about it. Oral sex.
Yeah.
Does that include, is that included in the transmission?
Yeah.
Yes, because let's say in the female anatomy, how far is the vagina from the,
Yeah.
about 2 centimeters, right? So therefore, are there microscopic fecal matter in the vagina?
could be.
When you go what? That will actually make it worse because when you bathe, the feces now is in the water and it can enter the vagina. Shower would be better. Bathing is not the same as shower.
That's what they stated there.
Bathe in the shower. You shower in a bathtub, yeah, but don't bathe in the shower. No. For NCLEX, no, okay, not for the NCLEX.
Okay, take a shower.
All right, so, okay, let's finish up because we still have ATI. Table 43-4, this is a nice, they already made the table for you. So this one tells you how it's spread. So A and E, here A and E are both oral fecal.
Table 135.
Yeah, you can disregard the, what?
What's the difference between A and E?
Nothing really. The only thing I can say is the, well, used to be in the older edition of the textbook, they said that the E is only found in certain countries, but now, I mean, now we have flights everywhere, so it's really, there's no difference, okay?
So the transmission is the same.
Yeah, the same. So contaminated food and water, oral fecal route. You can disregard the second row. I mean, I'm not gonna ask, how many days you'll have this symptom. No,
This is-
because they're all resemble the manifestations except for the chronic forms, because B, C, and D are chronic forms. A and E are only acute. So B, C, D are chronic forms. So there will be no acute symptoms, obviously, right? For B, C, and D. So only A and E will have the acutely severe symptoms of the GI, the nausea, vomiting, diarrhea, abdominal pain, pruritus, and the jaundice, okay? Because this can lead to acute liver failure if not treated.
Are we treating?
Oh, number one is rest. There's not really much. For A, it's symptomatic. We let you rest. NPO, we keep you alive on fluids until because it's viral, so it'll resolve. Yeah. We just need to stay alive until it resolves. Okay, you understand?
That's why
Yeah. Yeah. So nowadays, though, at least we have treatment for B, C, and D now. Okay. We even have vaccine for B, right? For D, you can only get D if you have B. Okay, because D cannot enter the cells unless there's already, it's like a RNA thing. Okay, so it needs the hepatitis B virus RNA in order to enter. Okay, so if you're exposed to D, you can't get it unless you already have the B, because otherwise it's not capable of entering the cell. You need B to get D. Okay, yeah, so right. So you can't, even if you're exposed to D, you'll never get it unless you have B already prior. Obviously, there's no vaccine for C, right? We do have a vaccine for B. So therefore, can you prevent D?
Yes.
By getting the B. Okay, very good, children. No, we have treatment at least, but no vaccine yet.
But we don't have treatment for B.
We have treatment for B. We can treat hepatitis B now. Yeah, used to be it was like HIV. You had it forever, but no, we have treatments now. Okay, it's good now. Finally. Yeah, it was just recent during my time because my buddies had I'll just call him Johnny. Okay, just Johnny, California. He was really promiscuous. He, like prostitutes everywhere. Him and Glenn's in Canada. So both got hepatitis from the prostitutes. Okay, so at that time there was no treatment. So finally, they lived to today, and then they got treatment finally, okay, when the treatment came out. So again, some of these questions might be select all, okay, as far as the prevention is concerned. Okay, so pay particular attention to wherever you can get the fecal matter. All right.
You know, this chart don't really
Correct.
say the mode.
Yes, the table. Yeah.
Where's that?
The white part. Right there. Right there, right there. The
What part?
On the bottom. Gone.
I don't see that.
It's over
What's the white
on
part?
the next page. That's not it. You can just get the mode. Yeah.
Well, that's the main thing.
The mode.
That's the main. Well, if it's not here, then it'll be in the paragraphs. Yeah.
I think it's in the paragraph.
So again, how is A and E getting? How do you get it? A and E, oral fecal, B, C, and D,
You gotta get B.
blood and body fluids. Okay.
So A, E, it's easy.
Mhm.
B, C, D.
Oh, I see.
And you need to get right.
Correct.
Yeah, I remember that. How many select